Welcome back to the Deep Dive. Today, we're tackling a really vital area for advanced practice, Chapter 53 from Pharmacotherapeutics for advanced practice, focusing on weight loss pharmacotherapy. This isn't just academic, is it? It's right at the front lines of a major public health issue.
Oh, absolutely. It's unavoidable, really. I mean, the source material points out, 42.4% of U.S. adults are obese now? That's up massively from around 30% just 2 decades ago. So our mission today is to, dissect the drug tools we have, but we have to start with the sheer complexity of obesity itself.
Right, okay, let's unpack that foundation first. Before we even whisper the name of a drug, it's critical to get that this is multifaceted. It's not just, eat less, move more. There's a huge genetic component. The chapter mentions BMI heritability is estimated somewhere between 40% and 70%. That's significant.
It really is. And you take that genetic leaning, then add our environment, like constant access to cheap, high-calorie foods, and then layer on the body's own physiology. The body actually fights back against weight loss. When calories drop, you see ghrelin, the hunger hormone, it surges. And satiety signals, things like leptin or GLP-1, they can become less effective. The body resists.
So knowing all that complexity, who actually qualifies for medication? Where's the clinical line drawn?
Okay, so the key point is pharmacotherapy is always an adjunct. It supports lifestyle changes. It doesn't replace them. The recommendation kicks in for patients with a BMI of 30 or more, or a BMI of 27 or more if they also have at least one related comorbidity. We're talking hypertension, type 2 diabetes, dyslipidemia, that sort of thing. And don't forget, waist circumference over 40 inches in men, 35 in women, that's another big red flag for cardiometabolic risk.
That distinction is so important. And yeah, let's hammer that home. Drugs are adjuncts. The foundation is still reduced calories, getting in at least 150 minutes a week of aerobic activity plus behavioral therapy. But, the motivation is there. Even losing just 3% to 5% sustainably gives real health wins, lower triglycerides, better blood glucose.
Exactly. The drugs help create that energy deficit needed for the lifestyle stuff to actually, work and stick.
All right, let's start with the oldest group then. The noradrenergic appetite suppressants, or anorexians. Phentermine is probably the best known one. What's the immediate headline limitation with these?
Duration. Simple as that. They're strictly short-term. We're talking FDA approval for 12 weeks or less. Why? Because tolerance often develops pretty quickly. Their effectiveness just fades over time for long-term use.
And how do they work? What's the mechanism that also informs their risks?
They're noradrenergic. Basically, they poke the hypothalamus into releasing more norepinephrine. Norepinephrine signals don't eat, so it directly suppresses appetite. It's a central nervous system effect.
Okay, so boosting norepinephrine, that immediately makes you think about contraindications. What systems are under stress here?
The big one is the cardiovascular system, which means, careful screening is non-negotiable. These are an absolute no-go for anyone with a history of cardiovascular disease, CAD, heart failure, arrhythmias, stroke. Also contraindicated in uncontrolled hypertension, hyperthyroidism, glaucoma, and crucially, anyone taking MAO inhibitors. That combination risks a hypertensive crisis, which can be fatal.
Wow. So meticulous monitoring of heart rate, blood pressure is essential. And these are Schedule 3 or 4 drugs too, right? So
Yeah.
There's abuse potential on top of the cardiac risk.
Precisely. And the common side effects line up with that CNS stimulation, dry mouth, maybe dizziness, insomnia, feeling kind of jittery or restless.
Okay. So if those CNS risks, especially the cardiovascular ones, rule out phentermine for a patient, let's pivot. What about orlistat, that's Xenical, or Ali over-the-counter? This one's interesting because it's the only FDA-approved non-prescription option, and it works totally differently, right? Non-systemically.
Exactly. It's unique. It basically stays put in the GI tract. Its mechanism is pretty straightforward. It's a gastrointestinal pancreatic lipase inhibitor. It physically latches onto those lipase enzymes and stops them from breaking down about 30% of the fat you eat. So that fat just passes through undigested.
Which makes counseling on how to take it absolutely critical. Prescription is 120 milligrams 3 times a day. OTC is 60 milligrams 3 times a day. What's the crucial timing rule?
It has to be taken during or up to an hour after a meal that contains fat. If there's no fat, there's nothing for it to block. And this ties directly into counseling about fat intake, keeping it under 30% fat per meal, ideally. That's key to managing the predictable side effects.
Ah, yes. The notorious GI side effects. How do you even begin to counsel someone on that, knowing that if they slip up on the fat intake, things could get messy?
You have to be direct, really blunt. Explain they will likely experience more frequent bowel movements, maybe urgency, fatty or oily stools, and yes, the infamous oily leakage or spotting, sometimes with gas. The source notes this can just be intolerable for some people. That's why sticking to that low-fat diet isn't just advice, it's essential for making the drug usable.
Beyond the urgency factor, what about drug interactions? Anything critical there?
Yes, definitely. Because it blocks fat absorption, it also blocks the absorption of fat-soluble vitamins, A, D, E, and K. So patients need a multivitamin containing these, but they must take it at least 2 hours apart from the orlistat dose. And two other key separation times for practitioners to remember. Levothyroxine needs at least a 4-hour gap, and cyclosporine has to be taken 3 hours after orlistat. Otherwise, absorption is compromised.
Got it. Okay, let's shift gears to the newer systemic agents intended for longer-term use. About the injectable liraglutide, marketed as Saxenda for weight loss.
Right, liraglutide. It's a GLP-1 receptor agonist. So it has benefits for glucose control too, but for weight loss, the mechanism is activating specific neurons in the brain, the POMC neurons. This sends strong satiety signals, basically telling the brain, you're full, which leads to decreased food intake.
And what's the clinical sweet spot for Saxenda? Who's the ideal candidate?
It's often preferred for patients who are obese or overweight and have type 2 diabetes, especially if they also have established cardiovascular disease, ASCVD. Because it tackles both weight and offers some cardiovascular risk reduction, it's a really strong choice in that population.
Now, the dosing starts low and ramps up slowly over weeks. Why the slow titration?
Yeah, it starts at 0.6 milligrams daily, then bumps up weekly over 5 weeks to get to the 3 milligram target dose.
Sure.
That's purely to manage GI side effects. Nausea and vomiting are pretty common initially, and the slow titration helps the body adapt. And crucially, don't forget the boxed warning, risk of medullary thyroid cancer and multiple endocrine neoplasia type 2. A personal or family history of those is an absolute contraindication.
Right. Okay, moving on to combination therapies.
Sure.
First up, phentermine ER combined with topiramate, which is Qsymia. We know phentermine suppresses appetite. What does the topiramate add to the mix for weight loss?
So you get the immediate appetite hit from phentermine. Topiramate's exact contribution isn't perfectly mapped out, but it seems to do a couple of things. It likely enhances GABA activity, which can reduce food intake, and it also inhibits an enzyme called carbonic anhydrase.
Okay, let's pause on that carbonic anhydrase inhibition.
Yeah.
That has specific side effect implications, doesn't it?
It does. It can mess with electrolytes, leading to hypokalemia, low potassium, and potentially metabolic acidosis, so those need monitoring. But honestly, the biggest flag with Qsymia is the mandatory REMS program, the risk evaluation and mitigation strategy.
Ah, the REMS. That's tied directly to the risk of birth defects, right, if taken during pregnancy.
Yes, specifically orofacial cleft lip or palate if there's exposure in the first trimester. It's a significant enough risk that the REMS program is strict. It requires prescriber certification, pharmacy certification, and mandatory pregnancy testing before starting and monthly thereafter for women of childbearing potential, plus strict counseling.
That's a major clinical consideration. Okay, last combination. Naltrexone SR with bupropion, which is Contrave. This one seems to target reward pathways more.
That's right. It hits two key brain areas, the arcuate nucleus, like other appetite suppressants, but also the mesolimbic dopamine reward circuit. By stimulating POMC neurons there, it seems to dampen the rewarding, sort of feel-good aspect of eating certain foods, so it addresses not just hunger, but also cravings and maybe eating for pleasure.
And hitting those reward circuits, again, brings us to a boxed warning.
Yes, another important one. Contrave carries a boxed warning about potential suicidal thoughts and behaviors and serious neuropsychiatric reactions. So you have to monitor patients really closely for any mood changes, depression, anxiety, hostility. On the flip side, a potential plus, bupropion is also used for smoking cessation, so if you have a patient trying to lose weight and quit smoking, Contrave could potentially tackle both.
That's a neat synergy. Okay, let's try to put this all together now. The chapter uses case studies, which are super helpful for decision-making.
Yeah, they really illustrate how patient factors drive the choice. Take their first case, AP young woman, prediabetes, hypothyroidism, and she gets migraines. Vitals are stable. What jumps out as a good option?
Well, Qsymia, the phentermine topiramate combo.
Yeah.
Right, because topiramate is also used for migraine prevention. So you're potentially hitting two birds with one stone. And orlistat might be less ideal, not because it's dangerous, but because she's on levothyroxine for her thyroid, and she'd have to separate those doses by 4 hours. That's a big adherence challenge.
Exactly. Now, flip to case study MB. A 40-year-old guy, but his hypertension is uncontrolled. BP is 15298. He also has type 2 diabetes, A1C is 8.8, And importantly, he refuses injections.
Okay, uncontrolled hypertension. That immediately knocks out phentermine, phentermine and naltrexone bupropion because they can all raise blood pressure or heart rate. Liraglutide is injectable, and he
Right?
refuses those. So that really only leaves orlistat as the viable oral option.
Right. And that choice immediately dictates the counseling. You have to zero in on the fat restriction, the GI side effects, the vitamin supplementation, the levothyroxine timing if you're on it. These cases really show how often contraindications or patient preferences basically make the choice for you.
Absolutely. And then there's the critical monitoring piece, the 3-month rule.
Yes, essential protocol. Monitor monthly for the first 3 months, then every 3 months after that. And here's the benchmark. At that 3-month mark, if the patient hasn't lost at least 5% of their starting body weight, the medication probably isn't effective enough for them. The recommendation is to stop it or switch to something else. Continuing isn't justified given the costs and risks.
And quickly, about other options, the chapter cautions about most OTC supplements, right? Except ALI, the lower dose orlistat.
Yeah, it emphasizes that besides ALI, most dietary supplements lack solid evidence for weight loss. While some drugs like metformin are studied off-label, sticking to the FDA-approved agents is generally the way to go for safety and proven efficacy.
Good point. So, wrapping this up, what are the biggest takeaways for our learners from this deep dive?
I think the number one thing is meticulous patient assessment. You have to match the drug profile, its mechanism, its side effects, its contraindications to the individual patient's health status, their comorbidities, their lifestyle, especially screening for cardiovascular issues and uncontrolled hypertension before even thinking about the noradrenergic drugs. That's paramount.
And remembering that these drugs are tools to help create an energy deficit, making those lifestyle changes, hopefully, more achievable. But the source is clear. They don't fundamentally rewire the body's long-term weight regulation. So weight regain after starting the drug is unfortunately pretty common.
Which leads nicely into a final thought to chew on. We know there's a strong link, often going both ways, between mood disorders like depression and anxiety and obesity, and we just talked about serious neuropsychiatric warnings on some of these agents. So how might a patient's underlying psychological health, their coping strategies, affect not just the initial choice of therapy, but their ability to stick with it and maintain any loss long after that initial 3-month check-in? It adds another layer of complexity to truly patient-centered care and weight management, something definitely worth considering in your future practice.